So one way that we can think about AI and the promise of AI is how do we unlock value in healthcare? There's lots of talk about AI is going to transform healthcare. It's going to digitally revolutionize the way that we deliver care. But how do we actually measure that impact in a way that is tangible, that actually demonstrates in the way that we measure value in healthcare that there truly has been a benefit from AI? And so all discussions about value in healthcare really ought to start with this value equation, where value in healthcare is measured by quality over costs times experience. So those are the three main drivers. We always want to improve our quality, decrease cost, and create these exceptional experiences for our patients. And AI in healthcare really does have that opportunity to transform and increase value in healthcare. There are examples in each of those domains where where AI has truly provided value by improving quality, decreasing costs, as well as in creating exceptional experiences. And some of the examples really have been in reducing the healthcare administrative burden of delivering care. So for example, helping with clinical documentation. So for many of you, some of you are clinicians, maybe doctors, nurses, and the administrative burden of clinical documentation has really been a source of contention within digital transformation or initiatives adoption of the electronic medical record. So that is one area that has been exploding when it comes to ambient scribes and really being able to provide clinicians the return of joy to practicing medicine, because nobody goes into medicine to be on the keyboard, fiddling with the computer system, but to have that impact with direct patient care. Other areas where AI is reducing the administrative burden include the electronic medical record, interpreting, summarizing large volumes of information, helping with communicating with patients, with automated or semi-automated draft messages to patients when they have clinical concerns, identifying potential risk of drug-drug interactions, and then helping with appointment scheduling and optimizing scheduling. So many examples where AI is already either improving the quality of care or decreasing the cost. And for many patients, finding a delightful experience. There definitely have been examples or studies that show the quality of the, say, communications from an AI drafted system can be a little bit more empathetic, more complete than doctors traditionally when we are going through our emails. Sometimes we can be a little curt. So that experience even has been enhanced through the use of AI. Now, those are right now, but when we think about the real future of AI, it is this idea of this concept of multimodal AI, a pathway to personalized precision medicine, where we're really integrating multimodal data sets, whether it's data from your electronic medical record, from imaging, from our genomics, all of these data points, which currently live in silos, separate, not able to provide additional insights, but being able to leverage multimodal AI, where all of those insights are now able to provide almost like a digital twin of an individual and provide personalized, prescribed interventions. That is the future of AI when it comes to this pathway to personalized precision medicine. And yet, are we there yet? No. I wish I could say that we already are on this path to personalized precision medicine. If you go to the doctor's office today, most likely you're going to have a pretty similar experience as you did last year or the year before. And that really, there are just so many barriers when we think about adoption of AI in healthcare. There's this statistic that has been presented that 80% of AI projects fail in healthcare. And if you talk to Dr. Horowitz, who's the chief medical officer at Microsoft, he's been trying to translate digital transformation into clinical care for over 20 years. And he states the impressive barriers to translation of AI to healthcare practice may result in no change to the practice of medicine in 5 years, which would actually be, of course, a travesty. So, what are those barriers to success? Why is it so hard to translate digital innovation into clinical care, into the bedside? And there are many barriers to AI success, and these are generally the four main buckets. One is that healthcare is really complex, and there's really no two health systems that are the same. So, even if you have one instance of Epic, let's say I'm on Epic at the University of Utah, and you're on Epic at the hospital close to UNT, those two instances of Epic were using the same electronic medical record, but there's a saying that if you know one instance of Epic, you know one instance of Epic. That does not necessarily mean it's going to be the same experience for you, and the workflows may be very different in Texas than they are in Utah. So that complexity really makes it difficult to implement at scale. Then there's AI regulatory uncertainty, even the litigation risk. If you talk to many health systems, a lot of their AI governance is risk-based, and litigation risk being one of those major risks that come to mind when we think about the immaturity of even quantifying what that litigation risk is. And then immaturity in AI governance. So AI governance is new. Many health systems haven't figured out how to implement it. And then real concerns about ethics, about bias, about who can potentially be harmed by AI and who will benefit from AI. So I think it's really important that we understand what is AI bias in healthcare. So bias, first of all, what is bias? I mean, often we can, words are politicized, but really these are just mathematical, statistical terms. So AI bias in healthcare refers to the systematic differences in how an AI algorithm generates predictions for different patient populations. So an algorithm may systematically produce one outcome for one group of patients and then another for another. How that bias manifests, there are many different ways that bias manifests. It can be non-representative, where a patient population is underrepresented in the data set, the way that a data scientist actually creates a model, including choosing proxy variables. There are historic disparities, and that all leads to this cycle of bias that can perpetuate in a model. So bias, again, is this systematic error. It's just deviation from ground truth, and it occurs at each stage of the AI lifecycle. It can start with problem formulation. So for example, who gets to decide which problems are important problems that AI solves? Well, if you ask pharma, they may focus on a disease state like diabetes that's prevalent and affects a really affluent, say, US population, but we may have greater need for AI someplace else that are underserved or understudied disease states, diseases that are more likely to affect populations that don't have isn't a well-defined market. Another area in the life cycle includes data creation, so just sampling bias. If you think about who shows up in your health system's care delivery system, you may have patient populations that never come to your health system. And so you have this systematic sampling bias where those populations just aren't represented in your healthcare data set. Other areas include data acquisition, so that would be measurement bias. And then the human factor of developing the model. So when a data scientist get a data set, that there often aren't well-defined, say, data columns for a particular outcome you may be interested in studying. And so you need to transform the data in ways to best approximate the outcome that you're trying to predict. And those are human decisions. The model evaluation process, how rigorous the model is evaluated after the model was developed, and then deployment, because you can have a perfect model that is deployed in an imperfect world, and then it continues to need to be evaluated and monitored to ensure that it has the outcome that it intended. So when you think about, what's at stake, it really is the scale of decision making that is so different with AI than it is with, say, I as a physician. If I make a biased decision, if I make an error in healthcare, I as an individual physician, it's a one-on-one interaction. I say I make a mistake and one patient is harmed. As a healthcare executive, let's say I'm in charge of, say, diabetes management in my healthcare system. If I make an executive decision for the system, now that impact may be 1 in 100,000 or 1 in a million, depending on what that system level impact is. But now, as a data scientist, if you create a model that's deployed in hundreds of health systems, maybe thousands of health systems, that scale now is exponentially greater and can be, global. I use this particular number because that's a particular model that was exposed to over 80 million people that was flawed. And so data scientists and the way that AI is deployed can have such a huge scale that is dwarfed by our traditional way of delivering care. And so what are the stakes of for your population? And I'll go through 3 use cases that show what happens when AI is deployed with poor or flawed, say, governance. The first use case you probably have all heard of. It's well documented. It's the Obermeyer et al. What they found when an algorithm learns the wrong lesson. Basically, what they obtained a large data set, and what they noticed is that systematically Black patients had a precipitous drop-off in referral rates for case management on a national level, and they couldn't figure out why one year the rates were X, and then the next year it had dropped precipitously. And so when they went sort of dug deeper, they realized that an algorithm had been deployed across hundreds of health systems, actually population health management platforms, and that model was flawed. They found that Black patients were 50% less likely to be referred to case management while being equally sick. And then they were able to work with the owners of the model and identify ways to improve it, to just fix that error. The error that had been made was a proxy. They used cost as a proxy for a need. And it turns out in the United States, generally through a wide variety of systemic barriers, Black patients, while being equally sick, actually seek less care and spend less healthcare dollars. So without putting race in the model, the model had systematically decreased the estimation of need for these Black patients. And what they did is kind of logical. Instead of using cost as a proxy for need, they substituted a different proxy, which is the number of problems on the problem list, and whether or not diabetes was controlled or not. So more clinically relevant proxies for need. If I'm a doctor and I see a problem list with 10, 20 problems on the list, I know that's a pretty sick patient. At the same time, if I know that their hemoglobin A1C is out of control, I know that that's patients at pretty high risk for clinical complications. So they basically just used logical proxies for a better approximation for need, and that fixed the algorithm. So after the fix, 84% of bias was reduced by 84%, and equally sick patients were referred for case management. That opportunity cost, again, about 80 million patients have been exposed to that model because it was deployed in hundreds of health systems, 100 of population health management platforms, and the estimated cost is over $1 billion in lost opportunity cost for health systems because you can actually charge for these services. Well, that's for the health system. What about for the patient and the family? Now, we do know that case management is a way that patients and families can navigate the healthcare system. And so without that service, this complexity of navigating healthcare was left to the patient. And so you know that out-of-pocket cost can be enormous. So Another case study, this is an epic sepsis prediction model. When an AI model is trained on data from an academic medical center in one location and then generalized to another care setting. Well, researchers at University of Michigan found that when that model was deployed, sepsis model was deployed that was designed at University of Michigan, was deployed in a rural healthcare setting. Actually, it was in Texas, 2 emergency departments in Texas, and the sensitivity of the model went down. It went from 67% sensitivity, 33% sensitivity to 14% sensitivity, where 67% of sepsis patients were missed in the academic medical center, and 85% of sepsis patients were missed in the emergency department in a rural community in Texas. So goes to show that building in one setting does not mean that model is generalizable to another healthcare system, and that it needs to be validated against that specific deployment. Another case study is from United Health, their NaviHealth NH Predict. This particular model was deployed in a Medicare Advantage population. What was found was that once this model deployed, the referral rates to SNFs went down by 9%, 9 times increase in SNF denials. So it was at one level and then 9 times decrease in SNF denials after it was deployed. An example was a patient, Gene Logan. This is actually working its way through the courts. He fractured his leg at 91 years old, and his physical therapy coverage was cut after 19 days, which is actually pretty clinically egregious. No 91-year-old recovers from a fractured leg in 19 days. It just makes no clinical sense. So his family had to pay out of pocket over $150,000 for his continued care, and he ultimately passed away from complications of the fracture. Presumably could have been prevented. In this particular case, the model denied coverage, and when they went back, only 0.2% appealed that denial. And of those 0.2%, 90% were approved. So turns out that the physician and the clinical team couldn't do the appeal. It had to be the patient and their family. And most patients and family members don't have even the skill set to be able to effectively appeal. But when they did, their appeal rate was over 90%. So 3 cases, 1 pattern, 1 is scale. So the Obermeyer example, at this point now, it's over 200 million people. It's now fixed, but it's still the number of frequency of population health risk assessment type models are over 200 million people a year. Epic sepsis models, of course, Epic's in over 3,600 hospitals in the United States. Globally, it's even more. In the United States, over 300 million records. So when a model goes wrong or it's deployed in one setting and another and not validated, that's a real problem. And then for the NH Predict, United Healthcare is the largest Medicare Advantage provider, over 9 million enrollees, and that's who was exposed to that particular model. When you think about who's at harm, it's generally those that are underrepresented in the data set. Wide variety of different populations, wide diversity of populations. It could be race, it could be community versus or urban versus rural, academic affluent neighborhoods versus less represented neighborhoods, age, payer mix. But the root cause is this challenge of having adequate representation within your data set for the particular patient population that's being modeled, using wrong proxy variables, no human override. So a lot of these root causes that AI governance can help identify and fix. So the consequences, of course, misdiagnosis or delayed treatment, exacerbated health disparities, and inappropriate treatment recommendations, and ultimately trust. So there's this healthcare AI paradox. One of my colleagues at UC San Diego, Dr. Karen Singh, say that researched AI tools aren't implemented, and implemented AI tools aren't well researched. So you have this paradox of really high adoption of low evidence AI models, and often it's because they are embedded in the electronic medical record, or they're embedded in platforms that healthcare systems or population health management systems have adopted as part of a platform. Or in the case of the prior authorization algorithms, that they're just completely separate from the healthcare delivery system behind the payer wall. And then you have high evidence, low adoption of models that you've been developing in academics. So many of our colleagues our academic colleagues create these really well-researched, well-developed, even randomized controlled trial models that don't have the dissemination that some of the other models have. And then there's this gap between AI adoption and AI governance. So you have a wide number of models that are already deployed. Over 80% of health systems use AI on a regular basis, and yet only 10% have effective AI governance. So the most consequential AI decision isn't necessarily what to build, but whether it should be deployed, how it should be deployed, and under whose watch. You may think, well, maybe the federal standards, maybe the regulations will help us. Well, no, that isn't the case. There are no federal standards. It's actually the current federal environment is seeking to erode some of the standards that states are trying to write. So many states, there are actually over 250 healthcare AI bills introduced across 34 states. Colorado's probably been one of the more early adopter, and their AI governance is actually delayed. The future is uncertain. They've actually been targeted by the federal EO, that should be said EO, executive order. At Utah has a pretty interesting policy that includes heightened healthcare AI disclosure, and then it has a special carve out for mental health chatbot rules. In Texas, you have two different laws in effect, and where patient disclosure is recommended when AI systems are being used. But at the federal level, Washington is not writing any more AI governance. There are some FDA and ONC governance in effect, but even that has been not necessarily enforced. And it's trying to prevent states from implementing their own regulation. So what's left really is institutional governance. What you do as an institution to protect your patient population is the last step. So how do we right-size AI governance? Because only 10% have effective or some form of AI governance. And so we created this healthcare AI risk maturity model that allows for right-sizing AI governance regardless of what your resources are. And so this healthcare AI governance readiness assessment assesses 7 domains, 5 different maturity levels, and you have these large academic medical centers that generally are level 4 or 5. Most health systems are at level 1 or 2, where they're really just getting started with capability development in those 7 domains. So when it comes to those 7 domains, organizational structure, do you have a leadership? Do you have, when it comes to problem formulation, do you have a clearly defined use case for deploying AI within your health system? For the algorithm development, do you have data collection, or at least some sort of model card on how that model was developed and how it performs specifically against your own population? How about the external product evaluation and selection? Do you have a process for evaluating the product selection? How that model is evaluated within and validated for your local population? What kind of information do you have and performance against your local population? When it comes to deployment and integration, have you thought about how it integrates within workflow? And then monitoring over time. So once you've deployed a model, you've gone through, say, steps 1 through 7. Are you continuing to monitor for performance, for accuracy, for safety, for impact, for outcomes? So those are some best practices. There are a lot of different both techniques from an AI governance, people coming together, determining policy and process, and then the technical tools. So it's this challenge with AI governance is that it really takes both. It takes organizational initiative, policy, process, but it also takes this technical skill that many healthcare systems do not have. At academic medical centers, some of the leading academic medical centers have developed even automated AI monitoring systems for the technical components. One of my colleagues, Brett Bolio-Jones, has created this Argos, which is an automated AI monitoring system that ensures continuous patient safety. They automate the bias detection, mitigation, outcomes, and assess the impact of AI on clinical patient behavior. Clinical patient outcomes. They're just one of many. There are actually probably about 5 different academic medical centers that have developed similar types of approaches of semi-automated or automated monitoring, in addition to their sophisticated sort of AI governance from a policy and process perspective. So one of the challenges, though, is that these academic, well-resourced academic medical centers that both have the dollars, but also, which it may be more scarce, the talent to be able to deploy a rigorous AI governance system, both from an operations perspective and a technical perspective, can create this gap, a gap between, say, community health centers that just don't have the technical nor the resources, the human capital, and the financial capital to create a robust system. Where do they start? And so the healthcare AI readiness assessment really is designed so that wherever a healthcare system is, they can at least start with level 1. Start with some simple questions, even if you have 1 or 2 dedicated resources that can start the AI governance process. But one other opportunity, though, is through community partnerships. So we know that we have these models of community partnerships where academic medical centers or large health systems share their, say, instance of Epic, their IT knowledge and resources with community partners. Epic has a program called Community Connect. And so there is this shift towards a similar type of model for AI, responsible AI community partnership, where large health systems partner with smaller, say, community hospitals, hospitals within their network, and provide AI governance assistance to these smaller health systems. So even when you talk about these larger health systems, AI governance continues to shift. AI governance itself is an evolving process. The process itself was defined in a sort of generative AI era. And many, including one of my colleagues, Dr. Singh, has pointed out that we now have this problem in generative AI, in the generative AI era, of this archaic process of one by one, model by model evaluation. But there's this proliferation of generative AI use cases that AI governance is not able to keep up with. For even those large academic medical centers, how do you manage all of AI? It's like it's this tip of the iceberg kind of problem. They manage most health systems that do AI governance are able to manage the tip of the iceberg, but you have this whole generative AI proliferation of use cases that's sort of below the surface. So how do you navigate that? How do the health systems navigate it? The old way was, and the probably more prevalent way is, okay, for those that's below the water, you just prohibit it. Prohibit without an usable alternative. You say that no generative AI products can be used that we don't have direct oversight over. But what that creates is shadow AI. So it doesn't necessarily create a solution that's sustainable over time. You just create a different problem because every day there's some sort of new product out there that your clinicians, that your users are exposed to in their day-to-day life, and they want to use it at work, right? So, for example, Claude Desktop is now available. You can install it onto your local computer. You can use Claude Desktop with your, or even Perplexity computer, hook it up with your local email and your drives, and you're off to the races, right? That's probably not currently a acceptable use if you don't have the right enterprise tools. So the preferred path is to create these enterprise tools and codes of conduct for this lower, sort of more pervasive, lower risk, more pervasive use cases, where you say, okay, we're all adults. This is our code of conduct. We've created all of this enterprise suite of, say, HIPAA compliant tools that are safe to use in our environment, that have passed our security and privacy requirements. You guys can explore within this safe sandbox kind of environment. And we have in place a way to audit and escalate. So if I'm a user and I find, okay, this is getting kind of, I think I might be on the edge of an acceptable use here that maybe not, maybe outside the scope of the policy, why don't I escalate that to my chief AI officer, chief health information officer? And then that particular use case can be fleshed out, and then everyone can share and learn together. So that's the preferred path versus the prior or the current way that we generally deploy AI governance. So when we think about the shifts for AI governance in 2026, we have three sort of major shifts. One is this shift from that device by device or model by model individual review to a two-track governance architecture, one where you got the highest risk are closely governed, and then the lighter, you have a lighter track for for, say, human in the loop generative AI tools that is policy driven. The second shift is, again, that shift towards a community partnership model, where instead of it being just one institution at a time, trying to figure it out, self-sufficient, leveraging each other's knowledge, but especially academic medical centers or well-resourced medical centers, partnering with community health systems to help accelerate their growth in AI governance. And then the third shift is this shift from sort of technical governance, where you're just doing your fairness metrics and your evaluation, model evaluation process, looking for drift, all those technical components, but now expanding AI governance to really include multi-stakeholder within your governance systems. A recent critique of the National Academy of Medicine AI Code of Conduct was this gap where nursing was missing. Shouldn't nursing be at the table? They were probably one of the most prolific users of AI within our healthcare systems. So governance without community voice is just really governance for the privileged. We want to make sure that we have diversity of voice when it comes to AI governance. So we each have a role to play to ensure the future of AI-enabled healthcare is safe and effective. And I'd say one thing that each of us can take away with is these 4 questions that matter. No matter what you're doing, if you're a data scientist, if you're a key stakeholder, if you are a clinician, if you're in AI governance right now, these 4 questions. 1, what populations were used to train and validate this model? And does the training data include patients like ours? Only you at the local level, only local communities can best identify what a patient like yours actually looks like and be able to identify use cases for testing whether if that population is actually, if that model actually works for that particular population. Then what is the tool's performance disaggregated by race, ethnicity, age, rural, insurance type in our population? The third is, can clinicians or an expert human override the AI recommendation? And is that override documented and tracked? And then the fourth, and this is specifically for generative AI, is what data is retained, where, by whom, and under whose control.